Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of therapeutic products that have not been approved by the U.S. Food and Drug Administration, off-label uses of approved products, or data that were presented in abstract form. These data should be considered preliminary until published in a peer-reviewed journal. Readers should verify all information and data before treating patients or employing any therapies described in this or any educational activity. A qualified healthcare professional should be consulted before using any therapeutic product discussed herein.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Jazz Pharmaceuticals, Inc.
Hello, and welcome to this Medscape educational program entitled Case Review in Narcolepsy and Idiopathic Hypersomnia, integrating treatment decisions that prioritize sleep quality and cardiovascular risk. I'm Dr. Michael Thorpe, Professor of Neurology at Albert Einstein College of Medicine and Director of the Sleep-Wake Disorder Center at Montefiore Medical Center in the Bronx, New York. And I'm delighted to be joined today by Barbara Hutchinson, who's President of the Chesapeake Cardiac Care and Medical Director of Flourish Research in Bowie, Maryland. Welcome, Barbara.
Happy to be here.
So this activity is going to include the discussion of therapeutic agents, and some of them are not FDA approved, and I will be making reference, and Barbara will, where appropriate, to off-label use of medications for hypersomnias. So first of all, what I'd like to do is to present a case. And this is a case of a Sylvia, who's a 38-year-old Caucasian woman. She works as a full-time personal accountant and spends long times at a desk, reports low motivation and low energy when she exercises. Her diet's pretty inconsistent. She skips a lot of meals during the day, and she often has large dinners at night. She's had been diagnosed as having moderate obstructive sleep apnea syndrome about 2 years ago, and she's been using CPAP for a good amount of time at night, at least 6 hours. And compliance testing has shown that her residual AHI has always been less than 5. However, despite that, she continues to report fatigue, dozing off during activities, particularly when just sitting there quietly, not doing much in front of TV, for example. Now, she also has type 2 diabetes. She is overweight. She has a BMI of 34, so she is obese, and she has hypertension as well. So obesity, diabetes, and hypertension. She doesn't have depression, and there's no history of substance use. Barbara, how often do you see tiredness and fatigue in patients that are diabetic and hypertensive that are obese?
Actually, pretty often, because just the cardiometabolic abnormality in itself sometimes lends itself to increase in fatigue.
So here we have a patient who has obstructive sleep apnea syndrome, which appears to be under good control, but she does have this tiredness and fatigue and may well have significant sleepiness. And she has these other medical comorbidities, which could be a factor.
That sleepiness could be attributed to several things. One could be just sleep hygiene, poor sleep hygiene. Like I said, the metabolic disease or just a sedentary lifestyle because she sits a lot, Sylvia. Or it could she have residual obstructive sleep apnea because of that AHI that's still not quite where it should be. Behavioral adjustments and medication review, I think in Sylvia showed that there was no improvement despite all of this.
Yeah,
And
there's been a lot of discussion about this residual OSA, and some people have felt that it's partly related to inadequate treatment with CPAP. But there's also the fact that many of these patients with sleep apnea may have had their sleep apnea for quite some time before they get treated. And of course, their brain is being subjected to the cardiovascular changes and the oxygen saturation changes, which may be deleterious to their central nervous system function. So there could be a CNS component to this
sure.
sleepiness that we see in these patients that are treated with CPAP. Now, I see that she's on metformin and she's also on a GLP-1 medication, and she's taking that, I assume, for her type 2 diabetes, but also now, of course, GLP-1s are FDA approved for the treatment of patients with obstructive sleep apnea syndrome. The GLP-1 helps weight loss and also helps improve the sleep apnea in many cases. And she's also on lisinopril. Barbara, what about these medications? What effect might they be having on this particular patient in terms of tiredness and fatigue?
For example, the lisinopril for her blood pressure, the dose could be such that it is pushing her blood pressure down, and that could contribute to the fatigue that she may be feeling. And in terms of the metformin, if it's pulling her sugar again too low, that combination of the metformin as well as the GLP-1 receptor agonist, low blood glucose levels, or in some cases, if the glucose level is too high. So on either end of the spectrum, you can have fatigue.
How about the GLP-1s? I don't know that we know a lot about GLP-1s and their effect on sleepiness and sleep or nocturnal sleep for that.
I agree with you. That's why further testing is needed to see, is the effect on sleep an indirect effect? Is it because of the weight loss that it affects the sleep? But if I recall in some of the studies that they used the GLP-1, patients who used it were not necessarily obese.
Okay, in this particular patient then, there was the sleepiness, so she was referred to a sleep specialist for further evaluation, and it was found that her sleep apnea was under good control. She was using the CPAP for at least 7.5 hours, and when assessed by the sleep specialist, her residual AHI was less than 2, and there weren't any mask leaks, so she was using the CPAP very effectively. However, he did an Epworth sleepiness scale and found that she had a score of 17 out of 24. Now, anything above 15 is really severe sleepiness. So 17 is pretty severe sleepiness. And I would find it hard to believe that any slight residual apnea could be a contributing factor to that sleepiness, because that's far too severe for any mild sleep apnea that might be present. So it does appear as though there's something else going on. Her thyroid and B12 levels were normal, and I assume other blood tests that were performed were also normal and didn't explain the daytime sleepiness. Obviously, someone with this degree of sleepiness, you wouldn't want them taking sleeping pills or other sedative medications. They need to take those medications that we discussed for her diabetes and high blood pressure, but you wouldn't want her on any other sedative medications. She had further information came to light from her sleep studies. She slept well with a sleep efficiency of 88%. Anything above 80 is good, and particularly over 85% is very good. So most of the time she was in bed, she spent sleeping, and she fell asleep pretty quickly, 14 minutes. She went into REM sleep in 72 minutes, which is a normal REM latency. It wasn't shortened at all. Total sleep time for 15 minutes, and her apnea-hypopnea index, as we mentioned, was less than 2. Her oxygen saturation was good, mean 96, and didn't drop below 91%, so she certainly didn't have any hypoxemia during the night. There were no abnormal limb movements, so no periodic limb movements at night, and there weren't any significant arousals or respiratory events noted during the night, so there was no evidence that there was anything disrupting her nighttime sleep. What we have then is a patient who's doing well on CPAP, and so he went further to look at objectively as to how sleepy she was during the day and did this multiple sleep latency test. And on the latency test, he found there was a mean sleep latency of 6.3 minutes. So that means on average over the 5 naps, she fell asleep in 6.3 minutes. Now, normally you would expect it to be greater than 10, actually is normal. But patients who have significant sleepiness are less than 8 minutes. She did go into REM sleep during 2 out of the 5 naps. Now, normally we might accept 1 out of the 5 as being acceptable in terms of REM sleep, but 2 or more is particularly abnormal. And of course, that is consistent with narcolepsy. There was no cataplexy and no other REM sleep abnormalities noted during the study. What do you think about these main features in this particular patient?
Yeah, the residual, we still have to explain the residual excessive daytime sleepiness here. And I think from this MSLT, we're leaning towards narcolepsy.
Yeah, and there may be this complicating factor from the diabetes and the hypertension, and also obesity. Obesity is just by itself has been associated with daytime sleepiness as well, but at least her sleep apnea seems to be under pretty good control, doesn't it, with the CPAP? And so let's talk a little bit about essential disorders of hypersomnia, somnolence, and particularly narcolepsy and idiopathic hypersomnia. So typically in narcolepsy type 1, these are patients who we believe have lost the orexin in the hypothalamus, which is a main alerting neuropeptide in the brain, and they don't have that. And so they're chronically sleepy during the daytime. If you were to measure that orexin level in the spinal fluid, typically you would find it's very low, less than 110 picograms per mil. And these patients will typically have cataplexy, and that's the clinical feature that shows that they have type 1 narcolepsy. And then if you were to do the sleep studies and you were to do the multiple sleep latency tests, typically you find they have a mean sleep latency of less than 8 minutes, which is what Sylvia had, and they have 2 or more sleep onset REM periods, and she had that. So she met that criteria, but she didn't have the cataplexy, of course. And another way of diagnosing it on the sleep studies is looking at the sleep latency at night. Now, Sylvia had a normal duration, 72 minutes of REM latency, and if it's less than 15 minutes, that would indicate narcolepsy on the overnight polysomnogram. So her REM latency on the overnight sleep study was normal, so she didn't meet that criteria. But she didn't have cataplexy, and so it doesn't look as though she has type 1 narcolepsy. Now, type 2 narcolepsy, again, these patients are very sleepy during the day, and we don't really understand the pathophysiology, although it may be related to some subtle differences in orexin control in these patients, but we don't know that yet. If you were to measure orexin or hypocretin, it's the same thing in the spinal fluid, you typically will find that it's normal. And of course, these people don't have cataplexy, but the sleep findings on the multiple sleep latency are the same as for type 1. So they will typically fall asleep in 8 minutes or less and have 2 or more sleep onset REM periods. And of course, that's what was seen in Sylvia's case. By the look of it, she's meeting the criteria for narcolepsy type 2. Idiopathic hypersomnia is a little bit similar to narcolepsy, where these patients are sleepy during the daytime. They don't have the cataplexy, of course. And if you were to do those sleep studies, you find that they may be sleepy during the day. Not all of them are sleepy during the day, but they definitely don't have the features consistent with type 1 or type 2 narcolepsy, in that they don't have any REM onsets on the multiple sleep latency test. Now, an alternative way of diagnosing idiopathic hypersomnia is to look at their sleep over a 24-hour period. And if they have more than 660 minutes, that's more than 11 hours of sleep, then that's consistent with the diagnosis of idiopathic hypersomnia. So at this point, it looks as if Sylvia is meeting the criteria for type 2 narcolepsy. She had those sleep onset REM periods. There's the Epworth Sleepiness Scale. That was very high. We don't often see that in patients on treatment for sleep apnea. So the fact that she had such a high Epworth, to me, is a telling point that she may well have something else going on, either idiopathic hypersomnia or narcolepsy. But there weren't any other REM sleep phenomena that she was reporting. there was nothing else to really give a clear clue that she could have narcolepsy, so you were really dependent on the sleep studies. And then there's the metabolic comorbidities. They still may be playing a part, don't you think, Barbara?
Her high blood pressure and her diabetes, sure. Because like I said, those metabolic comorbidities by themselves could cause you to be sleepy.
Yeah, yeah. She's on CPAP, and of course now we need to consider treating her excessive daytime sleepiness, so we need to consider medications. These are the medications that are FDA approved for the treatment of sleepiness in patients with narcolepsy. And we have the oxybates, which are one of the prime treatments, pitolisant, which treats both sleepiness and cataplexy, which is a histaminergic medication, modafinil, armodafinil, and solriamfetol, which affect the neurotransmitters that are important in controlling the sleep-wake mechanisms. And of course, these potentially can contribute to cardiovascular issues. She does have hypertension. Any alerting agent can do that. I guess the one that doesn't is oxybate, but oxybates can be sedative and can worsen sleep apnea, so we have to be careful there.
And even in the oxybates, avoiding the high sodium oxybates because that could aggravate the hypertension.
Definitely, yeah. The sodium formulation could definitely be a problem. Now, there are alternative therapies besides the FDA-approved ones that we mentioned there. There's methylphenidate and dextroamphetamine. Some of these forms are actually FDA-approved for narcolepsy, but we're tending not to use them so much, which is probably a good thing, particularly in somebody like Sylvia who has hypertension, because these are more likely to aggravate hypertension. So we have Sylvia, who's a 38-year-old Caucasian woman. She's on CPAP for her sleep apnea. And then we need to consider an alerting agent for her that's not going to worsen her sleep apnea or hypertension. And lifestyle changes, of course, are always important in somebody who has diabetes and obesity and hypertension. A number of things there are important, particularly structuring her sleep-wake pattern to make sure she's getting adequate sleep at night. And did you see any reason, Barbara, why we should change metformin or the GLP-1 or the lisinopril?
No, I think for the GLP-1, because of the data suggesting that they may also help with sleep apnea, I think it's good to keep that. And the lisinopril, an ACE inhibitor, would protect her kidneys from the effect of the diabetes. So I wouldn't change either of these. But I think the key is to know that in managing Sylvia, it's important to make sure that is a care team approach, not just a sleep physician, but the primary care doctor that's monitoring all the other cardiometabolic problems that she has.
Very good. Okay, so let's go to case 2. This is a 25-year-old woman who is tired despite getting 7 to 8 hours of sleep at night. She has difficulty waking in the morning and has a sleep inertia, nothing to suggest sleep apnea or narcolepsy. She is on an antidepressant for depression, but there's no other medical or substance use history. And she does work, however, as a bartender, and so she's working from 5 o'clock to midnight, and this does affect her sleep-wake pattern. Sometimes she's going to bed at 1 a.m., then on other days she goes to bed at 9 o'clock, and the time of getting up varies as well. So there is some variability in her sleep-wake pattern. But looking at her sleep diary, and she also had actigraphy, which measures sleep-wake patterns over a period of up to 2 weeks. And these showed that she was getting on average about just under 8 hours of sleep. And there was a lot of variability in her sleep-wake pattern, but she was falling asleep within 15 minutes and had very little awakenings during the night. Her daytime naps were often, but not refreshing. So that's one of the features we often see in narcolepsy is they tend to be refreshing naps. But her naps weren't very refreshing. But during this time that she was being evaluated, her sleep pattern was relatively good. And so she had 8 hours of sleep. She had a reasonably good circadian rhythm, and didn't appear that she was restricting her sleep. Now, she had a multiple sleep latency test that followed an overnight polysomnogram. And again, as with Sylvia, she was quite sleepy on the multiple sleep latency test, had a mean sleep latency of 6 minutes. So was in the pathological range there, but she didn't have any sleep onset REM periods. And during the MSLT, she was able to fall asleep easily, but went into stage 2 sleep, didn't get into any REM sleep. And when she woke up from those naps, she reported the naps as not being very refreshing for her. So we have pathological sleepiness as evidenced by the mean sleep latency and no sleep onset REM periods. So when we look at the differential diagnosis here, we're again looking at narcolepsy and idiopathic hypersomnia. In this case, because she didn't have any sleep onset REM periods, she really falls into the category of idiopathic hypersomnia, and the type where there is sleepiness detected on the multiple sleep latency test of 6 minutes, but no sleep onset REM periods. So the key features in this patient are the persistent sleepiness, nothing disrupting her nighttime sleep. She is a shift worker and she does have depression and is on an antidepressant, so that could aggravate her symptoms somewhat. However, it appears that she does have this idiopathic hypersomnia, and the differential diagnosis, though, does include that depression that she has, the SSRIs, the medications could be influencing it, and of course the irregular sleep-wake pattern. Barbara, how can we differentiate the idiopathic hypersomnia from patients who have fatigue related to depression?
Sometimes it's difficult to separate those. But I think in this case, based on the lack of SORMs that she had and her sleep latency, I think this is more idiopathic hypersomnia as opposed to depression-related fatigue.
And we don't think that the SSRI is playing much of an effect in her particular case, but sometimes SSRIs can disrupt sleep at night, but we had no evidence for that. In terms of treatments, now low sodium oxybate has been FDA approved for the treatment of idiopathic hypersomnia. In terms of improving alertness, there are a number of other medications that can be used, as mentioned on the slide: modafinil, pitolisant, clarithromycin, methylphenidate. None of these are FDA approved for the treatment of idiopathic hypersomnia, but they are sometimes used, and there's been a conditional recommendation from the American Academy of Sleep Medicine that they may be helpful. So in Jasmine's case, then, regulating her sleep-wake pattern was very important, particularly if she's a shift worker. You need to consider the possibility that the SSR is contributing to her problems, but her main treatment in this particular case is going to be to improve her alertness during the daytime, and most likely with the low sodium oxybate. And lifestyle changes are very important in her particular case. The main feature in her case was that she does have pathological daytime sleepiness without evidence of abnormal REM sleep. Now, Barbara, I think you're going to tell us about Ronald.
So the final case is Ronald. Ronald is a medical coder who works remotely, and he has a long-standing history of narcolepsy type 1 with cataplexy. And he's managed with pitolisant 20 milligrams and methylphenidate for some residual daytime sleepiness that he has. But despite this, he reports ongoing sleepiness, but good control of his cataplexy. Ronald is obese, he has hypertension that's controlled with an ACE inhibitor, and he has hyperlipidemia. He recently suffered an acute myocardial infarction after he presented with chest pain and EKG changes to the hospital, requiring urgent management. In following up with the cardiologist, he was started after his procedure, of course. He was started on aspirin, a beta blocker, statin therapy, and additional hypertensive medications to optimize his blood pressure. So the issues here in managing Ronald is, because of his recent heart attack, we now have to be very concerned what additional medications is added. So I'm going to just really talk about some of the medications that we have available and the cardiovascular effects. For example, pitolisant can prolong the QT. So obviously monitoring his EKG is very critical in this case. And he's on a beta blocker that can slow his heart rate. Any stimulants, you don't want a stimulant after myocardial infarction where you're trying to preserve the work of the heart. You want the heart to be slower, not faster, and the stimulants tend to do that. And again, we have to be careful here about interaction with other medications, the beta blockers plus the stimulants. The beta blockers slowing the heart down, and now the stimulants increasing the heart rate. The statins and some of the cardioprotective agents like pitolisant, that's metabolized by the liver, where the statins are also metabolized by the liver. So polypharmacy, we have to be careful. So when we look at narcolepsy, the management of narcolepsy in patients with cardiovascular risk factors or cardiovascular disease, we have to be very concerned about the stimulants that can increase blood pressure and heart rate. In terms of the sodium oxybate, like we mentioned earlier, these can increase the sodium load and increase the risk of hypertension. And pitolisant can prolong the QT interval. So the bottom line here in managing these patients, it requires a whole individualized approach, but also a team approach, because we have to look at the risk factors for cardiovascular disease or the cardiovascular disease itself, in this case, where he actually had a heart attack, any other concomitant lifestyle change substances, whether it's alcohol, caffeine, or cannabis, risk of any abuse or misuse of medications. We talked about drug interactions, the dosing schedule, and tolerability. So all these things we have to take into account as we make the selection for the patient. So again, in patients without any cardiovascular or cardiometabolic disease, in any case, we would monitor their blood pressure, their weight, their waist circumference, and also assess whether they have obstructive sleep apnea. We also implement guidelines for screening for lipids and hemoglobin A1C for diabetes. Patients with hypertension or a family history of cardiovascular disease, we have to be monitoring these throughout on a regular basis. So in conclusion, I know we have talked about patients today with narcolepsy, with idiopathic hypersomnia, with residual excessive daytime sleepiness. We talked about patients with active cardiovascular disease that have sleep problems like narcolepsy. The important thing to remember is that we have to tailor the treatment based on the overall symptom profile and comorbidities of the patient. We also have to account for the cardiovascular and metabolic risk as we make selections of the wake-promoting therapies. So we've been mindful of, in the cardiovascular patients, those that have hypertension, those that have an abnormal EKG, making sure that they are not on something like pitolisant that can increase their QT interval. And regularly measuring blood pressure, weight, the lipids, the glucose, and monitoring the EKG. So it's important to promote a collaborative care in these patients, as well as patient education, because it's important for the patient to understand the basis on which we make the selection of their medications to optimize their long-term outcome. So again, I thank you for this session today, and thank you for your attention.
Barbara, thank you very much for that. You certainly illustrated the great importance of considering the cardiovascular issues when it comes to the treatment with the medications, alerting medications, because of the sodium that they might contain, or the effect that they have on QTc interval, or the fact that most alerting medications can increase heart rate and blood pressure. So it's very important that we consider those in any patient that has any cardiovascular problems. I thank you very much, Barbara, for your presentation. I think this has been a great 3 cases that help illustrate the importance of assessing these issues in these patients with sleepiness. Please apply for credits, get your CME credits. I thank the audience very much for attending.